Hello everyone. In this lecture, I'm going to be talking about acid-base disorders. We will start by concluding what we started in the previous lecture, talking about minor regulators of acid-base balance, before we move into the metabolic disorders like metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Minor regulators provide supporting roles to major regulators of acid-base balance. They operate in specific organs of the body where they contribute to the maintenance of acid-base balance in the local area, but their effect may extend to other parts of the body. Although their contribution is physiological because it goes on continually, they may be affected by pathological conditions, and if they fail to respond appropriately, the condition may worsen. Some of the commonest minor regulators of acid-base balance discussed in this lecture include red blood cells, parietal cell of the stomach, ileal and colonic cell of the small and large intestine. The red blood cell contributes to the regulation of acid-base balance essentially in two ways. The first one is by contributing to the bicarbonate pool in circulation, and the second one is by mopping up the excess hydrogen ion by hemoglobin, which is in the red blood cells. I'm going to explain the process using this diagram. The red blood cell naturally has a very low supply of carbon dioxide because of its anaerobic type of respiration. Therefore, the carbon dioxide that is used in the process usually comes from the tissues. The carbon dioxide diffuses from the plasma into the red blood cell, where they dilute in water to form carbonic acid in the presence of carbonic anhydrase, which now dissociates into an hydrogen ion and a bicarbonate ion. The hydrogen ion is mopped up by hemoglobin in the red blood cell to prevent a buildup of hydrogen ion and acidosis, while the bicarbonate generated is supplied into the plasma to contribute to the pool of bicarbonate in the blood. And the bicarbonate that is pushed into the plasma is done in exchange for a chloride ion along this membrane. And this is what we refer to as chloride shift in the red blood cell. So, for every unit of carbon dioxide that diffuses into the red blood cell, there is a unit of hydrogen ion formed that's mopped up by hemoglobin, and there's also a corresponding unit of bicarbonate that is generated and pushed into the plasma. So any condition that will increase the amount of carbon dioxide diffusing from the tissues into the plasma and into the red blood cell will lead to an increase in the amount of bicarbonate that will be supplied into the plasma. So by this process, the red blood cell is able to contribute to the contribution of bicarbonate into the plasma and mopping up of hydrogen ion in the blood in a situation of an acidosis. This is the summary of what I have just explained. The red blood cell contributes to the regulation of acid-base balance by harboring the hemoglobin buffer system, which helps to mop up excess hydrogen ion, and it also contributes to the generation of a bicarbonate, which also helps to mop up excess hydrogen ion in an acidotic condition. And the process involves the diffusion of carbon dioxide into the red blood cell, where it reacts with water to form carbonic acid, which dissociates into an hydrogen ion and a bicarbonate. And the hydrogen ion is buffered by the hemoglobin buffer system, while the bicarbonate diffuses into the plasma. And in order to maintain electroneutrality, as the bicarbonate diffuses into the plasma, there is a movement of chloride in opposite direction from the plasma into the red blood cell to maintain electroneutrality. And this process is called the chloride shift. The second minor regulator I want to talk about is the stomach. The stomach naturally has an acidic pH because the gastric parietal cell continually secretes hydrochloric acid into the gastric lumen, and this is very essential for the digestion of food substances. However, every time the gastric parietal cell secretes hydrochloric acid into the gastric lumen, there's a corresponding secretion of bicarbonate into the plasma. And this particularly contributes to the pool of bicarbonate in blood, helping to maintain acid-base balance. In the gastric parietal cells, carbon dioxide from cellular respiration diffuses and dissolves in water in the presence of carbonic anhydrase to form carbonic acid, which dissociates into an hydrogen ion and a bicarbonate ion. The hydrogen ion formed diffuses into the gastric lumen, where it combines with a chloride ion coming directly from the plasma to form hydrochloric acid. At the same time, the bicarbonate ion generated from this dissociation moves into the plasma in exchange for the chloride ion along this membrane. Another example of a chloride shift. So while bicarbonate is being diffused into the plasma, a unit of chloride moves from plasma through this chloride exchange shift and parietal cell into the gastric lumen to form hydrochloric acid. While the gastric parietal cell is performing its physiological function of secreting an hydrochloric acid in the gastric lumen for the purpose of digestion, it is also at the same time contributing to the bicarbonate pool in the blood. Or it is logical to accept that the higher the amount of hydrochloric acid produced in the gastric lumen, the higher the amount of bicarbonate that will be supplied into the plasma. So any pathological condition that will lead to increment in the production of hydrochloric acid in the gastric lumen will consequently lead to the production of excess bicarbonate in the blood. For example, in a patient who is vomiting persistently, thereby leading to the loss of a lot of hydrochloric acid through the vomitors, and the parietal cell is making attempts to replace the lost hydrochloric acid by secreting more HCl into the gastric lumen, there will be a corresponding increase in the production of bicarbonate that will go into the plasma. The more the patient vomits, the more the parietal cell secretes hydrochloric acid to replace the lost HCl, and the more bicarbonate will be sent into the plasma. This will explain why patients who have persistent vomiting tend to have metabolic alkalosis because of the accumulation of bicarbonate in the blood, which will lead to elevation in the blood pH. Also, immediately after consumption of food, which will require a large amount of hydrochloric acid for digestion, there is a need for the parietal cell to secrete more hydrochloric acid into the gastric lumen to digest the food substances. So temporarily, after consumption of food, there is a temporary increase in the amount of hydrochloric acid, thereby leading to a temporary increase in the level of bicarbonate in the blood. And this is referred to as a postprandial alkaline tide, meaning that there is a temporary increase in the level of bicarbonate in the blood following consumption of food substances. This is the summary of what I have just explained. The gastric parietal cell secretes hydrochloric acid into the stomach and at the same time secrete bicarbonate into the plasma in exchange for a chloride ion in a process of chloride shift. And this process can also explain the postprandial alkaline tide that is found immediately after food consumption. However, the temporary elevation of bicarbonate in the blood is rapidly corrected by secretion of bicarbonate in the intestine, so that the alkaline tide does not persist for too long. Conditions that can cause excessive loss of gastric acid from the stomach, like gastric suction and prolonged vomiting, can also cause corresponding increase in the bicarbonate in the plasma, causing metabolic alkalosis. In summary, the stomach can contribute to the maintenance of acid-base balance by contribution to the bicarbonate pool in the plasma. The third minor regulator I want to talk about are found in the small and large intestine. Remember that the pH in the stomach is different from the pH in the intestine. The pH in the stomach is usually acidic due to the hydrochloric acid secretion, while the pH in the intestine are usually more alkaline because of the level of bicarbonate in that section. The alkaline nature of the small intestine is designed to protect the intestine against the acidic chyme or digested food that comes from the stomach, which is an acidic solution. The ilia and the colonic cells are responsible for the synthesis of bicarbonate in the ilia and colonic mucosa. And the process is a reversal of what happens in the gastric parietal cells. The process usually begins within the ilia and colonic cells, where carbon dioxide from cellular respiration dissolves in water from carbonic acid, which dissociates into bicarbonate and hydrogen ion. The bicarbonate that is generated is diffused into the ilia and colonic lumen, where they help in the digestion of food substances, and they are exchanged for a unit of chloride. This is also a chloride shift process going on here. So for every bicarbonate ion that is made going into the ilia or colonic cell, there's a corresponding exchange for a chloride ion which goes into the plasma in a process called the chloride shift, the reversal of what happens in the stomach. At the same time, there is one unit of hydrogen ion that is generated in this process, which is pushed into the plasma. So in a situation of alkalosis where there is a large amount of bicarbonate in circulation, the hydrogen ion generated in this process can help to combine with the excess bicarbonate to form carbonic acid and then form water and carbon dioxide, which may help to mop up excess bicarbonate in circulation. The other way by which the ilia and colonic cells help to contain or regulate acid-base balance is by production of this bicarbonate, which is lost in the body into the ileum or colonic lumen. The interpretation is that anytime there is an excess of bicarbonate in circulation, the hydrogen ion generated in this process can help to mop up that bicarbonate ion, convert it to a carbon dioxide in this process, which moves into the ilia and colonic cell, converted back into bicarbonate and is lost into the ilia or colonic lumen. So the ilia and colonic cells indirectly help to mop up excess bicarbonate in circulation while they are secreting the bicarbonate into the lumen to help in the digestion of food substances. So generally, there is a loss of bicarbonate from the plasma into the lumen of the intestine every time the ilia and colonic cell intervene in acid-base balance. Furthermore, it is logical to know that the higher the amount of bicarbonate synthesized into the ilia or colonic cell, the higher the amount of chloride that will be reversed back into the plasma. Therefore, any pathologic condition that will lead to the increment in the production of bicarbonate in the ilia or colonic cell will also automatically lead to the increment in the amount of chloride in circulation. For example, in a patient who is having persistent diarrhea, who is passing out a lot of stool in the gastrointestinal tract, that will be associated with loss of a high amount of bicarbonate. And in a bid to replace the lost bicarbonate in the ilia or colonic cell, the cells tend to synthesize a lot more bicarbonate and indirectly producing a lot more chloride that is going into the plasma. Because the higher the amount of bicarbonate produced, the higher the amount of chloride ion that will go into the plasma. And if this goes on for a very long time, it will lead to a situation where the level of chloride in the blood will become very high, leading to a situation of a hyperchloremic condition. So when a patient is having persistent diarrhea and losing a lot of bicarbonate in the stool, there will be an indirect elevation of chloride ion in circulation, and that is what we refer to as hyperchloremic metabolic acidosis, because the loss of bicarbonate in the stool will cause a metabolic acidosis. Also, in any patient who had had a cystectomy or any other type of ureteric diversion operation, where their ureter is connected directly to any of the small or large intestine segments, there's usually a large delivery of chloride into the small or large intestine. And because the small or large intestine usually have a preferential reabsorption of chloride, they tend to reabsorb large amount of chloride back into the plasma, leading to a high level of circulating chloride and hyperchloremic metabolic acidosis. So this is a common finding in patients who had cystectomy or any of ureteroileostomy, ureterocolonostomy, or ureterosigmoidectomy. This is the summary of what I've just explained. In ileal or colonic cell, there's a reversal of what happened in the gastric lumen. Chloride diffuses from the lumen into the colonic or ileal cell and eventually into the plasma, while bicarbonate diffuses in opposite direction. There is usually a net loss of bicarbonate and a net gain of chloride in the plasma, and this mechanism explains hyperchloremic metabolic acidosis in all the different type of ureteric diversion surgery that I listed below. Now, talking about acid-base disorders, they can occur when there is an abnormal secretion of acid in an excessive amount or when there is a loss of bicarbonate in the body. It can either be a metabolic or an alkalotic problem. Metabolic disorders are usually shown by changes in the level of bicarbonate, while respiratory disorders are usually shown by changes in the level of partial pressure of carbon dioxide, which can be shown in the result of an arterial blood gas analysis. The four major disorders are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. We will take them one after the other. Talking about metabolic acidosis, it is characterized by a drop in the blood pH following loss of bicarbonate, either through the kidney or the intestinal tract, impaired production by either the major or the minor regulators, or excessive buffering activity in a way that is more than the rate of production. It can also be caused by increased formation of hydrogen from any cause. Common causes usually include diarrhea, diabetic ketoacidosis, lactic acidosis, acute kidney injury, chronic kidney disease, and renal tubular acidosis of type 1 and type 2. The involvement of the kidney may be due to its inability to either reabsorb bicarbonate, regenerate bicarbonate, or secrete hydrogen ion into the urine. This will lead to a drop in the blood pH, which has consequences on structural and functional proteins in body. The lungs compensate for this metabolic acidosis by hyperventilating in order to get rid of excess carbon dioxide and return the pH to the normal value. And this compensation is very essential because metabolic acidosis can cause depressed consciousness, and it can even lead to coma or death in certain instances. Before we proceed further, I want everyone to try and attempt this question. How is bicarbonate reclamation related to renal tubular acidosis type 2? Please drop your answer in the comment section. In order to answer the question, I want to quickly revise bicarbonate reclamation. In bicarbonate reclamation, which occurs in the proximal renal tubule, filtered bicarbonate, which is unable to penetrate this lumen into the renal tubular cell, combines with hydrogen ion to form a carbonic acid which dissociates to water and carbon dioxide. Carbon dioxide, being a gas, is able to penetrate this membrane into the renal tubular lumen to combine with water in the presence of carbonic anhydrase to form carbonic acid, which dissociates into bicarbonate and hydrogen ion. The bicarbonate ion that is formed is reabsorbed back into the body. So essentially, in bicarbonate reclamation, filtered bicarbonate is reabsorbed back into the body through this indirect process. Now, how is bicarbonate reclamation related to type 2 renal tubular? In type 2 renal tubular acidosis, there is a defect in the proximal renal tubule such that the proximal tubule is no longer able to reabsorb filtered bicarbonate. As a result of that, most of the filtered bicarbonate are lost in urine. So in renal tubular acidosis type 2, where there is a defect in the proximal renal tubule, most of the filtered bicarbonates are lost in the urine. Therefore, bicarbonate reclamation is compromised. So the relationship between them is that anything that will affect proximal tubule, thereby causing a type 2 renal tubular acidosis, will cause an impairment in bicarbonate reclamation. That is basically the relationship between bicarbonate reclamation and type 2 renal tubular acidosis. Some of the causes of type 2 renal tubular acidosis are SLE, multiple myeloma, heavy metal poisoning, Fanconi syndrome, etc., etc. The same question can be asked about how bicarbonate regeneration is related to type 1 renal tubular acidosis. To answer that question, I will quickly explain bicarbonate regeneration once again. In bicarbonate regeneration, there is a de novo synthesis of bicarbonate which is sent into the blood. So there is a net gain of bicarbonate and there is a net loss of hydrogen ion in urine in bicarbonate regeneration. However, in type 1 renal tubular acidosis, there is a defect in the distal renal tubular cell where bicarbonate regeneration occurs. So the relationship between bicarbonate regeneration and type 1 renal tubular acidosis is that in type 1 renal tubular acidosis, where there is a defect in the function of distal renal tubular cells, the cell will be unable to perform bicarbonate regeneration, which will worsen the type of metabolic acidosis that the patient has. And some of the causes of type 1 renal tubular acidosis are SLE, Sjogren's syndrome, heavy metal poisoning, and amphotericin B toxicity. Now, talking about anion gap, the blood contains several positive and negative ions, but they are expected to be present in the same quantity in order to achieve electroneutrality. So, if all negative ions are subtracted from all positive ions, the answer should be equal to 0 because they are expected to be present in the same amount. However, because we do not usually measure all the positive and negative ions in the blood, we can establish a normal anion gap by taking advantage of the routinely measured positive ions and negative ions. So, the normal anion gap is the difference between the routinely measured positive ions and the routinely measured negative ions. Mathematically, a normal anion gap can be determined by measuring sodium, potassium, chloride, and bicarbonate and subtracting the addition of bicarbonate and chloride, which are negative ions, from the addition of sodium and potassium, which are the positive ions. So the value of sodium plus potassium minus the value of chloride and bicarbonate will give us the value of a normal anion gap based on the routinely measured cations and anions in the body. When the calculation is done, the normal anion gap is expected to be between 8 to 16 millimole per liter, accounting for all the unmeasured anions, including negatively charged proteins, phosphates, sulfates, and organic acids in the blood. In metabolic acidosis, where there is a reduction in the amount of bicarbonate in the blood. The medical condition causing the metabolic acidosis must produce another negative ion to maintain electroneutrality in place of the lost bicarbonate. For example, in lactic acidosis, there is a lot of lactate being generated, which is a negative ion to replace the negative bicarbonate which is being lost. Therefore, even though there is a loss of bicarbonate, there is a replacement of the bicarbonate by another negative ion in order to maintain electroneutrality in the blood. However, if we insert the value of sodium, potassium, chloride, and bicarbonate into the equation, there will be a high level of anion gap. Because sodium, potassium, and chloride are usually still intact, while there has been a drop in the level of bicarbonate. Such conditions are known as high anion gap metabolic acidosis. And some of the causes of high anion gap metabolic acidosis are methanol, urea, diabetic ketoacidosis, paracetamol poisoning, iron poisoning, isoniazid poisoning, ibuprofen poisoning, and all the other examples listed below. However, in some clinical conditions associated with metabolic acidosis, there are no alternative negative ions produced to replace the lost bicarbonate. In such conditions, there may be a higher reabsorption rate of chloride into the body, such that as the level of bicarbonate is dropping, the level of chloride is rising, for example, in hyperchloremic metabolic acidosis. In this situation, if the values of sodium, potassium, chloride, and bicarbonate are imputed into the formula, we will usually get a normal anion gap metabolic acidosis. Although the condition is rare, some of the causes are renal tubular acidosis, enteritis, gastric fistulae, excessive salt injection, normal saline infusion. Metabolic alkalosis, on the other hand, is characterized by an increase in blood pH following a gain of bicarbonate or a loss of hydrogen ion. So, any medical condition that will lead to increment in the blood level of bicarbonate or a loss of hydrogen ion in urine will lead to a condition of metabolic alkalosis. Some of the causes include vomiting, in which there is a major loss of hydrochloric acid from the vomiters, and while the stomach is replacing the lost hydrochloric acid, is inadvertently increasing the secretion of bicarbonate into the plasma, leading to a condition of metabolic alkalosis. Other causes include excessive aldosteronism, essentially in primary aldosteronism, in excessive antacid use in patients with peptic ulcer, and including NG2 function and diuretics. Now, the compensatory mechanism by which the body corrects metabolic alkalosis is respiratory acidosis, in which the lung retains a lot of carbon dioxide, either by hypoventilating or by having a shallow respiration. Also, the body tends to retain hydrogen ion in the body in order to correct the metabolic alkalosis. If you remember in the last lecture, where I talked about the reabsorption of sodium in exchange for either a potassium or an hydrogen. In this situation, where there is a shortage of hydrogen in the body will tend to reabsorb sodium in exchange for potassium rather than in exchange for hydrogen ion. So, for every unit of sodium reabsorbed, the body will rather get rid of a potassium instead of hydrogen in order to exchange or to reabsorb sodium and retain hydrogen ion in the body to ensure there is a balance in the pH. If this condition goes on for a long time, every time the body exchanges sodium for potassium, there is a loss of potassium in the body, and in the long run, this can cause a low level of potassium, which is referred to as hypokalemia. That is why metabolic alkalosis is usually accompanied by a situation of hypokalemia. Although it is important to say that metabolic alkalosis is less common than metabolic acidosis, and it is usually associated also with hypocalcemia. To explain how metabolic alkalosis is associated with hypocalcemia, note that hydrogen ion and calcium share the same binding site on albumin. So, so in a situation of metabolic alkalosis where there is a low level of circulating hydrogen ion, it means that more calcium ion will bind to the binding site on albumin, leading to an increase in bound calcium and a reduction in the level of free calcium. Remember that total calcium is equal to bound calcium plus free calcium. However, in metabolic alkalosis, where there is a high level of bound calcium, there is a reduction in the level of free calcium, which is the physiological calcium, which can reflect as a form of hypocalcemia, even though the total calcium is normal. So, patients with metabolic alkalosis can present with symptoms of hypocalcemia, even though the level of total calcium may be reported as normal. In respiratory acidosis, the hallmark of the presentation is hypoventilation, in which the patient is either unable to breathe very well or has a shallow breath. As a result of that, carbon dioxide accumulates in the lung and leads to the increase in partial pressure of carbon dioxide, leading to a situation of respiratory acidosis. The body compensates for this situation by increasing in bicarbonate production, especially from either the major or minor regulators of acid-base balance. In acute respiratory failure, the compensation is usually by the red blood cell, while in chronic respiratory failure, the compensation is usually from the renal mechanisms. Usual findings in respiratory acidosis include reduced respiratory rate, either due to a chest wall injury or if there is an airway obstruction or any kind of lung injury. And causes include pneumonia, asthma, foreign body inhalation, flail chest, and some of the other items I listed below. Respiratory alkalosis, on the other hand, is associated with any clinical condition that will make a patient to hyperventilate. Following hyperventilation, the lung exhale a lot of carbon dioxide, which will cause a reduction in the partial pressure of carbon dioxide and an increase in pH. The increase in pH will stimulate the renal mechanism to continue the excretion of bicarbonate in order to balance the pH change. Therefore, the appropriate mechanism to correct respiratory alkalosis is metabolic acidosis. Some of the causes of respiratory alkalosis include pulmonary edema, anemia, anxiety, hysteria, and brainstem diseases. To conclude this lecture, I want to talk about approach to blood gas analysis in terms of interpreting the results and arriving at appropriate diagnosis for affected patients. To start with, I would like to remind us about the Anderson-Hasselbalch equation, which says that pH is equal to pKa plus log of the conjugate base over log of the concentration of the weak acid, meaning that pH is directly proportional to the concentration of the base, while it is inversely proportional to the concentration of the acid. In order to interpret the result, the first thing to check is the pH of the patient. Is the pH normal, high, or low? If the pH of the patient is normal, it means that the patient does not necessarily have an acid-base disorder. However, if the pH is high, it means that the patient has an alkalosis, which may be either metabolic or respiratory. And if the pH is low, it means that the patient has acidosis, which may be either metabolic or respiratory. The second thing to check is the concentration of the base and the concentration of the acid, and to check which of them agrees with the pH. For example, if the base is high, that is alkalosis, but if the base is low, that is acidosis. If the acid is high, that's acidosis, but if the acid is low, that's alkalosis. So, any of the base or acid that follows the same direction as the pH will become the primary diagnosis of the patient. Lastly, we need to check for compensation of the acid-base disorder. That is, after establishing the primary pathology, we need to check if the patient is appropriately compensated for. So, in summary, check the pH of the patient if it is high, low, or normal. Determine which of the base or acid goes in the same direction as the pH. And thirdly, evaluate for compensation of the acid-base disorder. I have a few examples in the next slide which we will discuss. I am going to use this table to explain the interpretation of blood gas analysis using the result provided. In the results, we have the pH, which normally should range between 7.35 to 7.45. Any value below 7.35 is acidosis, and any value above 7.45 is alkalosis. Secondly, we have partial pressure of carbon 4 oxide, which is the respiratory component of the result, and it should range between 4.6 and 6.0 kilopascal. So any value below 4.6 is alkalosis, and any value above 6.0 is acidosis. Lastly, we have the bicarbonate, which is the metabolic component of the result, and normally should range between 22 and 30 millimoles per liter. So any value below 22 is acidosis, and any value above 30 is alkalosis. Now, looking at the first example here, the pH of the patient is 7.30, which is low and is acidosis. The partial pressure of carbon 4 oxide is 6.9, which is high and is acidosis, meaning that the respiratory component tallies with the pH. That makes it the primary pathology. So the primary pathology for this patient will be a respiratory acidosis. Now, going over to the metabolic component, the value of bicarbonate in this patient is 34, which is high and is alkalotic, meaning that the patient has metabolic alkalosis. So the interpretation for this result will be a primary respiratory acidosis, which is compensated by a metabolic alkalosis. So the interpretation is respiratory acidosis compensated with metabolic alkalosis. In the second example, patient has a pH of 7.28, which is acidotic, a partial pressure of carbon dioxide of 4.4, which is low and is alkalotic, and a bicarbonate of 16, which is low and acidotic. Between the respiratory and the metabolic component, it is the metabolic component of 16 which tallies with the pH, meaning that the patient has a primary pathology of metabolic acidosis. And if we check the value of PCO2, which is in the alkalotic direction, it will mean that the metabolic acidosis, the primary pathology, is compensated for by a respiratory alkalosis. So the interpretation will be a metabolic acidosis compensated for by a respiratory alkalosis. I will leave the rest of the questions for you to answer. Please answer the question and put the answers in the comment section. I will discuss them along the line. This is the end of the lecture. I thank you all for your attention. I will look forward to seeing your responses in the comment section. I will see you another time.